all people in our leadership it's the first time in Utah history that the minority caucuses and local chambers are led by all women and held by the policy managers. So I think that's important to mention because we're all here and we want to make sure our community voices are amplified. So now we go back and support. So and also now that I want to welcome all of you. I'll join you through the live stream and here with us in person to our session on equity. We are so grateful to have you here with us today and honored that we have such an important session that concerns law practice in its entirety during our first method. I think that's really important to emphasize that we're all here united. And many of us have faced the dynamics in the sessions. So it's so important we're all together and supporting each other and so we have a stronger together. Health equity is an essential conversation that has been brought to the limelight by the COVID-19 pandemic, when it became evident that the virus is disproportionately extended to people's color. While the importance of healthcare, we believe that the pandemic have not lasted it, it is crucial to keep having conversations and learning about health equity. In particular, our states that are passing legislation on eliminating DEI and how does that need to impact our community from a health perspective. The existing policy extends to every person of color in our nation. Some place several barriers to access to healthcare resources, including health coverage, difficulty with transportation, or limited facilities in their of our with it, and this become a matter of life and death for so many. We need to keep working to make sure race, ethnicity, social economic status, and geographic location, among others, are no longer, and I don't want to wear my reading glasses, so it's big font, are no longer barriers to receiving adequate, often life-saving care. Healthcare inequality, as I mentioned before, can be a matter of life and death. Outside of organizations like ours, it was seldom discussed before the COVID-19 pandemic, but has now come to the forefront on policies at all levels of government. We cannot allow it to be pushed back to the back burner. We need to pay attention, keep to understanding its significant implications, and prioritize it at a legislative level. National Hispanic Caucus and state legislators is proud of our continued commitment to bettering healthcare outcomes for all. We must keep working together as a quad caucus as we are here today, health equity and moving it forward. And that really kind of is important to name it the social determinants of health. We know that is a critical piece because it's not just the health equity, it's about all of the things that impact our communities. I am honored to introduce our next speaker, Senator Mary Kunish, President of the National Caucus of Native American State Legislators. Can you please join me? Let's put your hand.
Makayape, Petu Kanation Devashte, Mary Kunish Makayape, Dakota. I greeted you in language of my ancestors, the Lakota people. My grandfather and my mother are both members of the Standing Rock Nation. And I'm here to greet you with a warm handshake and a good heart. So thank you for inviting me down to your caucus for your session today. I'm really happy to be here. On behalf of the National Caucus of Native American Legislators, it is an honor to be here today in solidarity and partnership with the National Hispanic, Black, and Asian caucuses. Collectively, and this is really important, like collectively, we are a force. The Native Caucus relies on these partnerships to help address Native invisibility and work toward a future that looks much better than our past. Our 91 members, and I know we're the smallest caucus, but our 91 members become 1,400 when we work as a Quad Caucus. So thank you again. During Women's History Month, I'm honored to join the leaders and other caucuses to address community issues that impact all of our communities. Thank you to the National Hispanic Caucus of State Legislators for hosting today's session on health equity. I look forward to many opportunities like this in the coming year and exploring joint policy solutions and improving outcomes for all of our communities. Thank you to all of the members who are joining online and in the room today. And thank you to our speakers and to their expertise as well. And last, Robert Wood Johnson Foundation for seeing the value in the Quad Caucus and supporting our work together. And now please join me in welcoming the video message from Maryland Delegate Chris Valderrama, the leader of the National Asian Caucus of State Legislatures. Wopilatanka.
So the current chair of the hello, I'm hello. Hello, I'm Chris Valderrama, delegate representing Prince George's County here. Hello, I'm Chris Valderrama, delegate representing Prince George's County here in the great state of Maryland. And the current chair of the National Pacific American Caucus. I just express my sincere apologies that I cannot be there. Hello, I'm Chris Valderrama, state delegate representing Prince George's County here in the great state of Maryland, and also the current chair of the National Asian Pacific American Caucus of State Legislators, NAPACSL. I just want to express my sincere apologies that I cannot be there in person with my quad sisters, but we here in the great state of Maryland, we're leading up to Sine Die here. Days of session are end of session is approaching. But I did want to be here before all of you and to express how very important health equity is to our caucus and how we've taken position on issues such as data, disaggregation, cultural competency, and language access to address health equity and the Asian American and Pacific Islander community. Most importantly, we advocate for health equity for all of us. So we're so delighted to join this effort as part of the Quad Caucus and look forward to learning from the experts today. Also, in addition, I would invite you to our Quad Caucus webinar that is scheduled for next week, next Friday, March 29th, 1 p.m. Eastern Standard Time. Our webinar, Pushing Policy, Women Uniting for Legislative Change, will address our mutual policy issues impacting women, particularly women of color. With that, I thank you, and I look forward to seeing you all next week. God bless. Hello, I'm Chris Valderrama, State Delegate representing Prince George's County.
And now I want to introduce the president of the National Black Caucus of State Legislators, Representative Laura Hall of Alabama.
Good afternoon, and welcome to this session on health equity. I would first like to recognize our past president, Representative Billy Mitchell, majority leader for the state of Georgia. Please give her- I'm able to stand here and be proud of the fact that I'm a member of National Black Caucus of State Legislators because of all of the good work that he has done. So the National Black Caucus of State Legislators is a non-profit organization representing and serving the interest of African American state legislators. We have more than 700 members, which represents about 60 million Americans in 48 of our 50. The National Black Caucus of State Legislators also serves as a network and an information exchange and joint actions on critical issues that affect African Americans and other communities. So it's certainly a pleasure to be a part of this particular meeting where we're doing together to represent minorities in talking about the shared concerns that we have to health equity. And we know that through research, education, advocacy, us can strengthen our membership and will become a strong, effective, influential voice as we move to do work, not only within our community, but as we move to individuals on Capitol Hill, the concerns that we have. NBCSL was established in 1977 and is a platform for Black lawmakers to address um, issues that affect our community. In addition to being to advocate policy changes as well as promote social and economic justice. And over the years, NBCSL played a significant role in shaping policy, promoting social justice, empowering African American communities across the United States. And because of the advocacy efforts, we're able to, such as research initiatives, community engagement, and the organization continues to make a tangible difference in the lives of millions of Americans. And I believe because of that, that is why I stand before you today. We deliberate over resolutions such as health equity that have been submitted to our membership, and all of those resolutions were ratified by the full body. Then from that, it is disseminated to NBCSL state, federal, corporate, and nonprofit partners in order to affect change. It is such an honor for me to be here and be a part of this, and so I would my next responsibility is to introduce our panelists. First, I want to say welcome, panelists. We're certainly grateful that you're here. The first individual that I'm introducing is Dr. Sandra, no, I believe Dr. Sandra Harris. Looking for the last person. I have my names of individuals in front of me. Senator Mary. Oh, what's it? Okay, am I missing? Okay. Oh dear. Would you pronounce your name for me? Afshan Lahani. Afshan Lahani. Earl Evan Martin. Well, let me do this. Would you start from that in and tell us? Will you just start from that in and tell me who you are and other people that are in the audience, please? Thank you.
Conwell. I currently serve as Chief Diversity and Inclusion Officer, and also Senior Associate Dean for Faculty Affairs and Development at the Morehouse School of Medicine. I'm a practicing pulmonary clinical care and sleep medicine physician.
Thank you, Dr. Conwell. My name is Allison Belton. I'm the Director of Education and Training for the Satcher Health Leadership Institute at Morehouse School of Medicine.
Hello, everyone. My name is Evan Martin. I am the Program Manager at Satcher Leadership Institute at Morehouse School of Medicine. I'm a licensed master social worker.
Hello, everyone. My name is Satcher Lakani, and I serve as the Program Manager at the Kennedy Satcher Center for Mental Health Equity, and I am also a licensed practicing mental health.
Hello, I'm Sandra Harris. I'm a professor in the Department of Pathology, and I serve as Senior Vice President for External Affairs and Innovation. And I'm serving now as the Interim Director for the Satcher Health Leadership Institute at the Morehouse School of Medicine.
Thank you. And these wonderful individuals have made me look like I'm trying to do what I'm doing. And so they're going to be presenting on health equity tracker and how legislators can use that data to advance health equity legislations in their states. Thank you.
Switch this in. We already loaded.
Oh, I'm sorry. Not here.
Just do a slideshow.
He's them that they control.
Can you put it on slideshow for us? Slideshow.
I do apologize for all the technical mishaps. It's not like we practiced this twice yesterday. Yeah, here we go. Thank you, Mayor Kelly, for being great today.
Good afternoon once again. We at the Morehouse School of Medicine, on behalf of our President and CEO, Dr. Valerie Montgomery Wright, faculty, students, and staff, thank you so much for inviting us this afternoon to share with you some of the programs that are under our Satcher Health Leadership Institute. the Satcher Health Leadership Institute is one of several institutes at the Morehouse School of Medicine. And so I'm going to start by just giving you a snapshot of what the Morehouse School of Medicine is all about, Leadership Institute, and leave all of the time to my colleagues to talk about the particular program. The Morehouse School of Medicine was founded in 1975. So in 2025, we will celebrate our 50th year uh, as an institution. Yes. And you're all invited to come and help us celebrate next year. The Satcher Health Leadership Institute is one of several institutes at the Morehouse School of Medicine. But I want to start by saying in 1974, we set as a mission to what we're about, and that is to improve health care of all individuals and communities. Were put in place to diversify not only the healthcare workforce, but the scientific workforce. We do so through our education, research, and services programs. And most importantly, we do so to emphasize people of color, those that are underserved, not just in Atlanta, not just urban and rural, but throughout Georgia, the nation, and the world. And if we had time, we could share with you the numerous programs that we have in place that really do impact each of these sectors. We recently modified our vision, which is leading the creation and advancement of health equity to include in order to achieve health justice. And if you just marinate with you for a while, you would agree with us that in order to advance health equity, we have to achieve health justice. So this afternoon, this is my slide that I was going to use to tell you that Satcher Health Leadership Institute is just one of several centers and institutes at the Morehouse School of Medicine. Folks here in Morehouse School of Medicine, so they think medicine and that we train these students, and that is what we do. However, we train a number of other students. We have programs to train physician assistants, in Master of Public Health. We offer a PhD in biological sciences and a number of additional programs, master programs. Our education spans the gamut, and we have a number of research cores. But today we're here to share with you the program, some of those that fall under the Satcher Leadership Institute. As the name implies, the Institute was established by its founder, Dr. David Satcher, who many of you may know. And we're so proud that Dr. Satcher, even though he's supposed to be retired, he's still on campus with us at the Morehouse School of Medicine. We tell him that he failed. He actually failed retirement, and we're so glad that he did. The Institute's vision is to be the leading transformative force for health equity, and its mission is to create systemic change at the intersection of policy and equity. And once again, how can we be about advancing equity if we don't put those policies in place in order for that to happen? I'm not going to go through our schema about the Institute, but just to say that health equity is at the core of what we do. Our programs are around system transformation, mental health, behavior, and political determinism. And we do so within the framework, research, policy, engagement, and leadership. And that's what we will hear about from my colleagues in just a moment. Everything that we do is that we're going to share with you today is centered around a platform that's a tracker platform. You're going to hear from that. They are virtual today, but they will tell you details about the tracker, and our colleagues will tell you all about programs to the tracker. But what's most important about the tracker? You guys will say there's lots of trackers that talk about health, disease, entities, and what have you. But the key difference in the tracker that we use within the Satcher Health Leadership Institute and at the Morehouse Medicine is that it was established to be about health equity, not just about tracking diseases and disorders in communities, but the impact of health equity on those disorders. So I'm going to stop and just tell you that the agenda is that you will first hear from the Kennedy Satcher Center for Health Equity, an overview of that center. Then you'll hear about our project to end the HIV epidemic, and you're going to hear about the outstanding leadership objective initiatives that we have in the institute. And then you hear from those that lead and operate our health equity tracker. Once again, thank you so much for considering having us to be here with you this afternoon and tell you a bit about Satcher Health Leadership Institute at the Morehouse Medicine.
Good afternoon. Thank you so much for having us today. As I mentioned earlier, my name is Satcher and I have the honor and privilege of serving as the program manager for the Kennedy Center for Mental Health Equity. The Kennedy Center was founded by former Congressman Patrick Kennedy, who has done a lot of work and continues to do a lot of work around the space of mental health equity and then also mental health parity. Dr. Satcher, as we all know, did a lot of work of bringing mental health to the forefront during his time as a Surgeon General and coined the term there is no health without mental health. And so the partnership between the two of them really brought us to the Kennedy Satcher Center, where our mission and our work is very much focused around making sure we can provide equitable access and behavioral health care to all. As we've done a lot of research work and programming work over the years, we've started to identify key populations that we want to focus a lot of the work we are doing. And as my colleagues and I were preparing for today, one thing that we talked about was let's highlight the ones that will really stand out to this audience. And as I went to go do that, I realized I can't, because all the populations that we focus on at the Kennedy Satcher Center are very much intermingled within the group that's present here today with us and the different identities and different roles that we take on. And so our goal is that through the work that we are doing with the mental health equity piece and all of our research, policy, and programming work, we are touching and capturing the different identities and different perspectives that come from various walks of life. There are three key areas that Kennedy Satcher likes to focus on. One is research, and so in the field of research, we have put out two key papers that I will share with you all. One is the economic burden of mental health inequities in the United States, and the second is the 988 quarterly scorecard. So when 988 was launched, we did a pre-988 seminar that focused on what does equity look like within the launch of the 988 crisis line. A quarter after when the 988 line was launched, we then produced a scorecard that not only measured the equity, but also the access to the healthcare services and the services offered by 988. In terms of policy, we have released the 988 embedding equity into 988 policy brief that is available and talks about what are some active initiatives that can be taken to ensure that 988 is an equitable crisis line for all those that come across it. And then the third area that we very much focus on is convening leadership, where we bring together thought leaders to have conversations around what is mental health, what is mental health equity, and how are we bridging the gaps that currently exist. A quick snapshot of the work and some examples and how we connect back to the health equity tracker. So what you are looking at here is key research that was discovered through the economic burden of mental health inequities report that was released in September 2022. The health equity tracker allows us to see not only where there is a need for more mental health support, but if you go explore the health equity tracker, you can also see what is the suicide rate among marginalized populations in different states and by state that are impacting this economic burden of mental health. In terms of the equity scorecard, when we think about 988, we think about all mental health conditions and all support that is needed for all populations. And so the scorecard just captures what is the equitable access, what type of equity resources have been released by states to ensure that different populations know and have access to 980. The Health Equity Tracker also has a platform that is more live that allows us to track the need of various mental health support that's needed state by state and by populations. And then showed you convening leadership. And so one of the examples that I will share of our convening leadership is we did have a 5-series focus on what does criminal justice and equity look like in this realm, in the realm of mental health. And so we had 5 sessions that focused on an array of topics with the criminal justice involved population. And now our health equity tracker also has a platform that targets the violence and violence prevention on a state by state and national basis. And so a lot of the work that we do continues to feed back into the health equity tracker, or the work that has already been into the health equity tracker continuously builds on our work. We're hoping to continuously add more mental health data to the tracker, but also use these to help recognize more and more of the gaps that are present, not only on a state by state basis, but also a national level. With that, I will pass it to Evan.
Good afternoon, everyone. My name is Evan Martin. I'm the program manager at Satcher Leadership Institute, and I have had the honor of leading SHLIs in the epidemic initiative in my time there, and I'm delighted to be able to share our progress with this body today. As a general overview of the project, our goal is to examine the structural barriers impacting HIV or HIV care for Black communities across urban and rural settings. Predominantly, the goal of this is to work in the South, but project deliverables as they are currently constructed are focused on Georgia and Louisiana. We received a $4.5 million grant for this initiative from Gilead Sciences, partnered with Xavier of University College of Pharmacy, and they're replicating our deliverables in that region. So the project is comprised of several distinct boards whose primary objective, my colleagues have mentioned, promoting health systems transformation across the continuum of HIV care. And so I want to talk a little bit about those and how they tie into health equity track. So the first core is data collection. This core is responsible for understanding perspectives on HIV testing, treatment, and ongoing care in Georgia's Black communities. To conceptualize this information, the data core has facilitated key informant interviews and focus groups across urban and rural settings in the state with up to 146 participants. And that's inclusive of people living with HIV, community advocates, service providers, clinicians, and policymakers across the state. Next step, we want to be able to take and refine that information for further analysis and to be able to finalize a report to be able to publish those findings. The next core is the policy tracking, analysis, and education, which is to identify and critically review protocols, procedures, practices across various settings to determine whether they exacerbate or alleviate gaps in the care continuum for people at risk or already living with HIV. One of the commonly cited topics that we encounter in working in the policy space, policy sphere, is those who have experienced, working with the provision of health services, either those who are providing it or those who receive care, will encounter stigma. There's a great barrier of healthcare providers even being able to talk about sexual with their clients. And part of our task is being able to identify what are some policy solutions that we can actually implement that can make change. And that has been interwoven into many of the other project boards, the work that I'll go into a little later. This division is also focused on hosting educational webinars, which are some of these same issues that I'm talking about now from a policy standpoint, specific to how they're impacting Black communities. As you can see here, our policy team was pretty fundamental to a Champions of Change event that was held on March 15th in honor of National Women and Girls HIV Awareness Awareness Day, and we are developing preliminary steps towards hosting an event in April geared towards National Youth HIV and AIDS Awareness Day. The next core of the project of this initiative is Asset and Hazard Mapping, which is dedicated to mapping the unique challenges that people living with HIV and those at risk of HIV have in accessing resources in their specific region. So with an integration of GIS technology, firsthand experience, and being able to actually work with communities, we're able to identify parts of Georgia, the region where, say, for example, HIV care clinics are widely accessible, whereas in another part of the state they may not be. And that kind of data, the long-term trajectory of that kind of data is to be integrated into the health equity tracker, which I want to talk about in a little bit more detail a little later. So a pretty integral part of this work that we're doing is seeking the input from our task force that has been convened from a diverse range of Georgia-specific individuals and organizations who their unified goal is developing actionable strategies to counteract the region's HIV-related challenges. The members, some of who are represented here, attend monthly meetings, contribute to the development of the initiatives I've already described, and share program materials and education with their respective networks. So this task force, some of the highlighted members here are those who are doing their part to specifically inform our policy work. Indisa Moore O'Neill, for example, has been integral to the HIV criminalization work, the decriminalization of HIV in jurisdictions where that's still an issue. Charles Stevens, who's really highlighted the importance of narratives and being able to communicate about the HIV experience or the experience of those impacted by HIV. And we're also working in coordinated fashion with the city of Atlanta, through the mayor's office and the director of LGBTQ affairs, Malik Brown. Here we have represented in terms of their levels of expertise, including people living with HIV, those inclusive of those young adults, advocates, community service providers, rural health advocates, faith-based organizations, academic scholars and clinical practitioners, legislative policy experts, mental health professionals, and representatives from historically Black colleges and universities. So to tie all this together is the health equity tracker. As has been mentioned, is responsible for centralizing an array of health equity data across the U.S. Specific to this, it's focused on bringing a lot of data from the different courses as mentioned, and being able to make that widely accessible to a community. So that the goal of being able to do that was we went into this deciding that the tracker, the information that was going to be placed on the tracker would be informed by community. So the task force played a big role, actually having the tracker presented to them. They provided feedback about the direction, and ultimately that feedback has ultimately been implemented. The community is also connected in other ways because the platform is open source. Community partners such as those on the platforms and others can access granular level data for the marginalized people they serve to achieve policy objectives and other goals. For example, determining if a specific county or region in Georgia is underserved from HIV funding, they can highlight that from the asset and hazard mapping data that has been provided. And they can use that to advocate with their local legislators. We need to provide funding for this area. Other methods of community connection involve them being able to actually discuss their causes of interest from a wide range of focus areas, but a lot of our work is specific to HIV, and they can craft blog posts, articles, and also utilize the data platform to visualize what it is that they're speaking on. So through this development process, the HET, and by extension, Morehouse School of Medicine and Satcher Leadership Institute have been positioned as a trusted voice, which is unique in terms of how data sources typically work. That level of community input is maybe sometimes missing on the local and national levels, and that's a lot of responsibility that we've had to assume by making, and it's responsibility that is that we take very seriously. and making these community connections. This success has also prompted ongoing conversations with other community partners about integrating data sets on their platform. So specific to this program, in the epidemic initiative was focused on, or is focused on Black communities. Depending on the needs for future initiatives, this kind of work, the HET itself, can inform work reports on other vulnerable or marginalized communities. And the last step, the last core, last but not least, is the training and curriculum development core, which is tasked with equipping diverse healthcare professionals, learners, and leaders with knowledge on the social and political determinants of health. That next steps look like further training from the executive leadership standpoint for those who have been assembled with the project to encourage the importance of meaningful involvement of people living with HIV/AIDS. I'm going to transition now to Allison Belton, who will be able to tell more about that project and about SHLI's work from a health equity leadership standpoint. Thank you.
Thank you so much, Evan. As mentioned earlier, my name is Alice Belton, and I direct our leadership and training programs within the Satcher Leadership Institute at Morehouse School of Medicine. And so, how does leadership training fall into an academic setting? Well, we know within the Satcher Leadership Institute, we have a saying that comes from Dr. Satcher that says, "Everyone leads and everyone learns." And so, with respect to that, we, over our 15 time period, have equipped leaders of diverse backgrounds to foster policies and practices for health equity and disparity elimination. We know that these leaders are the ground force that can make these changes that impact the communities in which they live, work, play, and thrive. Our initiative has uh, involved a variety of professional and leaders that have spanned across a multi-sectoral approach. And our trainings carry a common theme and focus area of leadership development, health policy, health equity, and health systems transformation. And so we've been proud to say that over this 15-year period, many of our alumni have moved forward and continue to do very stellar work within the health equity space where they are. They now lead in positions within academic settings, also within healthcare, and that involves public sector and private sector, government, as well as within community organizations across the nation, and as well as within our territories. So I am happy at this time to highlight 4 of our initiatives that are currently taking place as a part of our training opportunities. And so as Evan transitioned, he was discussing our training opportunities within the Epidemic Initiative. And as you mentioned, the point of this particular project is to illuminate and highlight the disparities that are continuing to exacerbate and continue to serve as structural barriers for us being able to eliminate the the disparities that are faced around HIV and AIDS, especially among Black communities within the South. And so with this initiative, we have implemented some training programs. As you saw, he did highlight the webinars that have been produced by our policy core, which are part of our educational initiatives as well. But we also operate with a health equity leadership development program geared towards individual leaders who are health professionals and trainees, as well as those who work in community spaces, those who serve as policymakers and influencers such as yourselves, as well as those who are interested in making a difference and eliminating those structural barriers to HIV equity within the communities that we live. We also have an organizational workshop that goes to the organizations. These are typically healthcare organizations, and we've structured it where we are targeting organizations in our targeted area for our project, that being rural and urban areas in the state of Georgia, as well as in the state of Louisiana through our partnership with Xavier University of Louisiana. And so again, our targeted learners for this program include those trainees and healthcare professionals who are already working in the space and working with individuals and communities impacted by HIV aides, healthcare navigators, those who are working in the social service sectors, as well as community leaders and organizers and policymakers and influencers. Our next project, or our next initiative, excuse me, that we have is in partnership with pharma. And this particular fellowship is a fellowship for early stage researchers who are interested in data. So data falling into the health equity tracker is one way that we can determine and create equitable action-based solutions and recommendations that can go forth towards helping us develop and move towards health equity. And so, what we want to do with this particular program is bring these fellows in so that they are able to take the data that is housed within the health equity tracker and turn this data into actionable equity recommendations. And so, these particular fellows represent a number of areas. They may come from pharmacy, as with the tie to pharma, as well as the early career biomedical researchers, translational researchers, or those who are actually pursuing some form of career or some type of training, even at the graduate level in research. And so with this data, they are tasked with critically studying what data has been added based on medication adherence and treatment for specific chronic diseases in order to determine what the impact is on equity for a number of diverse populations, and to be able to promote these recommendations, not just within the public health sphere, but at all levels of government and organizationally as well. So we're proud to welcome these fellows in doing this critical work so that we can continue to work towards eliminating disparities in chronic disease management and treatment. So we take our partnerships and we value them as much as possible. And so we have a long-standing partnership with the Association of State and Territorial Health Officials. And this particular program, excuse me, entitled the Diverse Effective Leading in Public Health, focuses on training those individuals who are professionals within local, state, territorial government and who are interested in moving towards executive leadership in those spaces. These individuals are typically underrepresented at these higher levels, yet they are making such a critical difference where they are within their mid to senior level roles. And so we want to offer continuous aid towards personal and professional advocacy, helping them to form their leadership identity as it changes throughout their professional career, and help be involved in their career planning so that they can move forward and be promoted to these executive spaces, so that there are more individuals representing those who are experiencing the greatest disparities at the highest levels of leadership. And so our targeted learners, again, are mid to senior level governmental public health officials, again, who are serving in local, state, and territorial health departments, governmental offices, and governmental entities. And these individuals all represent members of an underrepresented identity group in leadership. Finally, we have partnered with the American Medical Association for the Medical Justice and Advocacy Fellowship, where we are looking to build advocacy leadership in physicians in order to enhance the health outcomes among their patient populations and promote equity all around. And so with this particular partnership, we have worked with 23 fellows who are representing a myriad of specialties and work across the nation, bringing in their various expertise in advocacy, including those who are working with their own state legislators to bring about various changes in policy recommendations with their own interests. And these individuals are set to implement excuse me, health equity projects focused on areas that pique their professional interest. And these health equity projects are implemented across various systems. They're implemented again, as mentioned, in their local vicinities and their states, as well as in academic institutions. And so we are looking to mentor and train these health advocates, because they are all health advocates, in institutional and political arenas. A lot of times we know that historically medical education does not go into the policy space. And so this fellowship offers that opportunity for us to extend that. So all of these trainings come together, especially with the health equity tracker as a viable resource and an essential training tool to help us equip leaders to convert data into action. So what can you all do in your various positions? You all can foster inclusive environment to bring in those who have been trained by programs such as these for coalition building. You all can emphasize training opportunities for your own staff as well as for yourself. We welcome you here. We've trained several governmental and elected and municipal officials through our training opportunities. So we welcome you into our training spaces. And we want you to be able to endorse these trainings as well for your staffers and those within your sphere of influence. And then finally, we invite you to inform yourself about reliable equity-focused tools to aid in policymaking and decisions. With that, I am glad to transition it over to our Health Equity Tracker team, who you all will see virtually, who can give you a demonstration of such a tool. Thank you.
Good afternoon. Can everybody hear me? All right, sounds great. My name is Ben Hammond. I am the senior software engineer on the Health Equity Tracker team at Morehouse School of Medicine. And I think we need to take a step back because we've heard about all of these amazing programs that are happening within Satcher Health Leadership Institute, and they've all interacted with the Health Equity Tracker. And we haven't gone into as many details of what the tracker actually is. So fundamentally, the Health Equity Tracker is a way to make data about health accessible to everyone, inclusive of the average user on the computer, to legislators, and then importantly to scientists, researchers, anybody that we have labeled a policy influencer, somebody that can affect change within their government, within their community. So I will give you sort of an overview of where the Health Equity Tracker started. And my colleagues, Eric and Kim, the three of us are the entire Health Equity Tracker team. We'll sort of give you the past, present, and future of the Health Equity Tracker. Next slide. So a powerful tool for fair health for all. There are a number of different disease trackers that you can find across the internet. A lot of these sprung up after COVID, and that's also what spurred the launch of the Health Equity Tracker. However, as Dr. Harris-Hooker mentioned at the very beginning, the goal for us was to create a health equity tracker, not simply a disease tracker. As the disease numbers were rolling in and 2020 lockdown, everybody saw very quickly that where you lived, where you worked, your race, your age, your sex, all of these factors could have dramatic impacts on how COVID was affecting you. And then also in terms of the comorbidities, diabetes, COPD, all sorts of conditions all combined. So what Satcher Health wanted to do, and we obtained a grant along with Google.org and a number of other funders to put this project together that would really emphasize the equity aspect of it for representing all sorts of marginalized groups and groups whose stories aren't always told within this data space. Next slide. So to start off, one of the founding principles for the tracker was transparency and accountability. We partner directly and closely with diverse communities, and we're clear about who interprets the data and how that shapes the overall health narrative, tracking the equity, not just the disease. And then more specifically, since we require relatively robust data to disaggregate by race, to disaggregate by sex, gender identity, this exposes a lot of holes and a lot of missing data. Some similar platforms, in terms of making their charts look nice, they just ignore the missing data. They gloss over it. We decided at a fundamental level that we want to lean in to showing where the data is missing, and if we can, why that data is missing, and what sort of policy changes we could make that would make a more fair data collection policy. Next page, please. Community first. People and communities drive our work. By making sure we collect data from underserved populations, we can help highlight what policy changes are needed to boost those communities. Unfortunately, as probably almost everyone in this room has recognized, when you're looking at a chart, you have to distill the data down. And far too frequently, for a number of reasons, because the data is not there, or because it's just too much work, that might turn into white, black, and other. And that is not enough to tell the story. And so we take the extra steps, we put in the extra work to represent as many of these marginalized groups as we possibly can. And again, we highlight when we're not able to represent those groups. So we really attempt to lift up these smaller populations rather than simply pushing them down into the footnote, putting it all together in a big bucket of other people. We invest all the additional effort as well. Every data set we present is national in scale, covering all of the states, but ideally down to the county level, which is a lot more relevant to individuals and their communities. And then we especially put in the work to find territorial data, which is another aspect of the United States that is almost entirely ignored on a lot of data tools. So it's extra work, but we feel that it's very important to make sure everyone is represented. Next slide. Open access is, as a software engineer, is one of my most exciting principles that we're founded on. It's the idea that every point of data, every line of code that we write is completely open to the public, not just for peer review and to check our math, but also to serve as a building block for the next researcher, for the next group. Whatever sort of science and research and equity wants to be done, you can use our app or pieces of our apps to achieve that. So we've ensured that community leaders partner with us and that we play an active role in determining what data to use when making these policy recommendations. So before any code was written, before the idea had even fully formed, a task force, separate from the previous task force we mentioned, was 55-member group of experts, community leaders, and people with lived experience that set the course for what this tracker would be. And I think, as you've seen throughout all of the presentations, community involvement is essential to everything that we're doing. And that's, before I wrap up, I think that's the best way to phrase it, is that a lot of this research, a lot of this policy design, a lot of it gets made and put on a shelf somewhere or put into a report that gets read and then, stored in the library. And our goal is to get this information and this data onto the internet in a way that is free, open, and accessible to absolutely everybody so that we can achieve health justice together. The next slide, I'll pass you over to Eric Warren.
Hello, everyone. My name is Eric Warren. I'm a software engineer here at the Morehouse School of Medicine. I'm excited to share with you the progress that we've made since the inception of the tracker. We collected some feedback from our users who currently use the tracker and asked them what are some of the things that we could do better and focus on with our tool. And one of the things that kept coming up was providing intersectional data. So on the tracker, we had a way of viewing data by age, race, and sex, but people were really interested in being able to see how race and sex intersect with one another, how age and sex intersect with each other. So we put together some tailorized reports for specific marginalized communities so that we could highlight them. So for example, just not looking at how HIV is impacting the Black community, but how are Black women specifically being impacted by that community, or excuse me, by that condition. So I think we've really made some great efforts to try to highlight those communities that often would be overlooked and give policymakers and influencers kind of a way to see where they should, put their focus and interventions on. The next slide. We've also, I think Ben just talked a little bit about missing data as well, and how that is in and of itself a major public health issue, and we are aware of that. And so that's another thing that also came up from our users, like where is data on trans people? Where is data on this marginalized community or that marginalized community? So we wanted to make sure that we started contextualizing and adding some notes on our visualization for conditions and populations that that you would expect to be there, but aren't there because we just don't have it either for reporting issues or collecting issues. And this also gives users the opportunity to not only see like what is missing, but also see maybe why it's missing. Like, why aren't we collecting data on trans people? Why don't we have the population counts for the trans community? Next slide. And lastly, we've also wanted to not just show equity from the present moment, but also we wanted to track how a particular disease is affecting communities over time. And this is one of my favorite visualizations because it almost reminds me of a progress report in a way, where it gives policymakers, influencers the opportunity to see, are the interventions that we put in place really affecting the communities that we want to affect? Are they helping the communities that we want to help? We can see that the disease is getting better over time for people, but there is a particular community where it's not progressing for them. So we want to make sure that we've implemented these time tracking capabilities on the tracker so that people have the information needed to really advocate for their own community and for themselves. This is all the work that we have done so far. I'm going to pass it off to Kim, who's going to discuss our future endeavors.
Aloha and good afternoon, esteemed legislators and guests. I'm Kim, the Health Equity Trackers team, user experience software engineer and product manager of the app. So as we wrap up an overview of the Health Equity Tracker app, I wanted to provide an example of how this innovative platform goes beyond mere statistics, offering a lens through which we can view the enduring impact of historical policies on present-day health outcomes. Next slide, please. The Health Equity Tracker serves not just as a repository of data, but as a narrative tool, telling the stories of communities through numbers and trends. Next slide, please. So as I go through this brief history lesson, I know, humor me for a few minutes, we can put into perspective the age-old question of how did it get like this? So for those not familiar with the ATL, we have one of their counties, Fulton, and just a few miles over, we have a neighboring county, Cobb. So while Fulton is newer than Cobb County, next slide, please. Next. And next. Fulton experienced a merging of two more counties in the 1930s. Next slide, please. Which drastically increased their numbers compared to Cobb by over 900%. Next. So on top of that, the roots of inequity go deeper. In 1935, the Social Security Act was passed, which, while revolutionary, it excluded large numbers of minority workers. This exclusion set a precedent, marginalizing Fulton County residents from economic and healthcare security, a gap that has widened over generations. Next. Fulton County bore the brunt of D grades, marking them as undesirable and hazardous. This redlining led to decades of underinvestment and a concentration of poverty, a legacy that is still evident today. Next, and next, and next, and next. So as we look away from the inner cities, you can see that the grading of the neighborhoods becomes desirable. Next 2 slides, please. Yeah, perfect. In the 1940s, the Hill-Burton Act was passed, requiring newly constructed hospitals to provide a reasonable volume of free or reduced cost care, which was supposed to benefit the underserved communities. However, these Hill-Burton hospitals didn't keep pace with the needs of bigger counties like Fulton, next, which aligns with the broader trend of an improving healthcare infrastructure in predominantly white suburban areas like Cobb County, and a trend of delayed healthcare investments in Fulton County. Next. So why is all of this important? Because on the health equity tracker, we take into consideration the relative inequity. Relative inequity paints a more complete picture of health disparities, one that takes into account historical, socioeconomic, and political factors. It highlights not just the what and the who of health disparities, but also the why and the how. Next, we do not merely see different health outcomes. We see the culmination of years, often decades, of policy decisions, economic conditions, and social determinants that have led to these differences. We begin to understand how factors like redlining, access to healthcare, employment opportunities, and environmental conditions have played a pivotal role. As legislators, this understanding is invaluable. It empowers you to make informed decisions, to craft policies that not only address current inequities, but also prevent future ones. The Health Equity Tracker isn't just about presenting data, it's about inspiring action, informing strategy, and igniting a commitment to health equity for all. So as we move forward, I encourage you to think of the Health Equity Tracker not just as a database, but as a gateway to understanding and addressing the complex tapestry of factors that contribute to health inequities in our communities. Mahalo nui loa, salamat po, and thank you so much for your time. And now I'll pass it back to Dr. Conwell over there in Atlanta.
We talked a bit about the history of Morehouse School of Medicine. And then we to focus on work specific social conditions. It's important for us to mind that those special factors, the political and social issues of health, may have emotional implications. And that's particularly true about the impact that policy decisions have had on the healthcare workforce. As be aware, coming out of the Reconstruction era, there were more than a dozen hospitals in labor for work. As a result of policy decisions, there was an inflection before 1980, all two of those hospitals closed. Very college Howard University for the next 60 years, two black schools between 1910 and the Civil Rights Act of 1964 went on to create more acquisitions by Texas and West in this country. Now they where they were still they couldn't increase their output to compensate the increase in the black population. And also for those schools also treated other physicians, Jewish physicians, Latino physicians as well. It wasn't until 1964 desegregation in our schools that we had an increase in the physicians created, and also had a reach of new schools Charles University, here in Morehouse, and currently, there's 4 institutions that still produce vast majority of applications today. But what about Morehouse doesn't recognize that the status quo cannot continue. We, the department, consider the second nonprofit system in the country to increase the number of Black and diverse positions that are being created. This partnership between universities and more alliance, where there's more than the 2 institutions that are different, will also be us to open 5 new routes and up to 20 new routes in programs. These institutions are spread across our nation, already in Florida, and Tennessee, Kentucky, and state of Washington. We are looking at the first FMS will be outside of the state of Georgia and Massachusetts, in order to take on the primary sponsorship for hospital training programs in Los Angeles and also.
The reason why this is important for you all to know is that these institutions, these programs and sites are spread in many of your states. And there are opportunities for collaboration. There are opportunities for advocacy in your roles as legislators. It's also important to keep in mind that we are just part of the solution. Our sister historically Black colleges and universities, Charleston University, is opening its own 4-year program in Los Angeles. Xavier University is partnering with Oshner Medical Center in Louisiana. Morgan State University just got approval to open its own osteopathic medical school. When we look at all this together in the next 5 years, we will have a total of 13 Black medical schools or Black medical training sites. That takes us back to where we were at the turn of the 20th century, before the Flexion Report. This is truly a historic time. If we consider as well work that's being done by our Puerto Rican medical schools, opening campuses on the mainland, we are truly fighting back the tide that is opposed to progressive efforts. So we encourage you to reflect on what we've communicated today and to think about this old adage about the arc of the moral universe being long and bending towards justice. And keep in mind that it doesn't naturally bend towards justice. It takes energy, it takes effort, and it takes partnership. So we look forward to partnering with you as we continue to bend that arc. We're happy to take questions now.
Have a question, the microphones are right here lined up, but I also want to remind people of time. So I will cut everyone off at 5:45 so people can go to the registry and do what they need to do, and maybe the panelists can stay after and talk. Go ahead.
I've been in representing the House for 20 years. The question is time. As you look at the issue of suicide data, is that certified? Here's information on Asian Pacific suicide, teen suicide, broken down, and if you can give more information on that,
Sure. So the Economic Burden of Health Inequities Report, we studied data that was studied from 2016 to 2020 or 20. And so while there is a racial and ethnic breakdown within that report, if you look at the equity market, there is more of a breakdown in terms of gender, and then as the race that breakdown, and I think there's parts of it that even have an age-based breakdown. So while the report itself uses data from a few years ago, the Bible that the Health Equity Tracker does allow for a little bit more of a breakdown. Now, I will say the report itself is available on Satcher Leadership and Kennedy Satcher's on our website, but look at the breakdown itself, you will see that there is a numeric value that shows what the economic burden is by race, but also the lives. And the lives itself are measured based off of, there's a level of premature deaths that we do anticipate. The number that is shown in the report is half that premature death number that is already anticipated. So you'll see that based on the data. One caveat I will say is the Asian the Asian suicide rate and economic burden is a little bit skewed because unfortunately there isn't enough data out there for us to adequately calculate that number. And so you'll see the disclaimer in the report too, but that in itself tells us that there are certain populations within just our groups and our identities here that are still needing more research and more efforts devoted so we can get more accurate numbers. I hope that answers your question. Absolutely.
Good afternoon. Thank you very much for the presentation. Representative Rolando Reyes from Connecticut. And this question is for you, Dr. Krull. So I'm looking at the data and really surprised that drug use affecting diabetes is not much higher. And my suspicion is because of the epidemic here in America, but the world, do you guys see the two curves section at some point in the fentanyl overdose and the fentanyl use actually?
I think Evan might be best positioned to respond to it.
Well, so what we've seen from a data standpoint, there are some gaps that exist. I think similar to the option was saying there's certain limitations. That's what we were able to collect just from the standpoint of the pandemic. But what is currently represented on the tracker, I think there is a need for more information about like where those two lines intersect. I would say that that's still something that is in progress of being added, and that would be a space where we would want more community partners to help with like giving more of an incidence on the intersection of drug use, use of drugs, and prevalence of HIV or incidence of HIV.
Okay, we'll take two more questions and then we'll and invite the panelists to come join us after.
Check. There we go. So I just want to flag something for the legislators in the room. I'm Andrew Zingali. I'm Gilead Sciences, one of the government affairs team. If you're an NHCSL member and you're receiving the monthly newsletter that they send out, if you keep your eyes peeled for periodically, we share resources through that newsletter around data and policy tools to address HIV epidemic, particularly in the Latino communities. Okay, so that may be of interest to you, something that we're going to continue to build out. I just want to thank NHCSL and the panel here for highlighting a lot of the work and partnership that's going on in the southern states. And then just quick shout out to the NBCSL folks who might be here. My colleague, Tony Mitchell, who works here in the southern states, just wanted me to say hi to you. So thank you.
Thank you.
Hello. Short people problem. I'm sorry. That's okay. Go ahead. Hi, everyone. Thank you for the panel. My name is Leonela Felix, and she, her pronoun. I'm from Rhode Island, a representative from Rhode Island. And I guess my question is, what can we do as legislators? Where do you see there is a gap in terms of data collection that we can use our legislative powers that be to be able to assist you all in collecting that data? So one of the things that was said is in terms of, for example, desegregating Asian American community from others and so on and so forth. But is there an area, for example, whether it's incarceration rates or others that we can work on that to help you collect that? Thank you.
Can the health equity team? I don't know whether they're still connected. So
Yeah, I can. So say the partnership is critically important. So as we think about the institutions, research institutions that might be present within your state, as we think about national partnerships, again, being able to partner with the Morehouse School of Medicine, the Satcher Health Leadership Institute, we recognize that no one entity can do this alone. And ultimately, it's actually the local partners, the community members that know where the greatest need is, and also are the trusted voices. Because in order to get much of this data, we actually need community members. We need your constituents to be willing to take part in research studies, being willing to share the data in census surveys. So making sure that you are partnering with your trusted voices and encouraging those community members to provide the data that ultimately will then feed into not only the research but the tracker. Thanks.
And I think we have one more question. We have time for that question, and then we'll wrap up.
Well, thank you for your presentation. My name is George Albert, State Representative in New York. My question is, what kind of performance indicator are you tracking to measure equity and accessibility of the calls to 988? And number two, you mentioned policy a couple of times during the presentation. You referring to your internal policy, or are you talking about state policy? And if it is a state policy, what policy you think that the state is lack of to help you to do your job better?
Sean, if you'd like to speak.
Yeah, so I'm sorry, I'm going to ask you to clarify one more time. So 988, what markers are we using?
Yes, so that's what kind of performance indicator are you tracking to measure the equity and accessibility of these tools?
Yeah, great question. So unfortunately, we at the Kennedy Satcher Center don't have our own data that's coming in. We're relying on a lot of the organizations and a lot of the centers that are fielding the 988 calls to get the data we receive. The quarterly scorecard and the reports that we have put out are based off of four areas, but mostly around accessibility of even making people aware that 988 exists right now. So a lot of the work that we're doing is even just in the idea of making sure people are aware that 988 is available. So it's the marketing efforts and the materials that are publicized to the groups. Is there what am I trying to say? A governing body that is overlooking what type of information is being made accessible about 988. We are also looking at, is there language diversity? Are we targeting the various populations that I introduced in my presentation? Because what we realize is a lot of 988 material that has been given out by states does target probably women, probably different race and ethnicity backgrounds based off of language diversity. But a key component is trauma-informed folks, so like our veterans and even individuals that have suffered from domestic violence situations or any trauma-involved populations. There is nothing that is catered to them. So a lot of our work right now is very much on what's given out in terms of just the awareness, but we are working with organizations to try to see what data we can collect back from them because we ourselves are not filtering data.
And then I think you have the policy piece of it too. What could states do, correct? Is that what you're asking?
So are you asking specific to like, because it go ahead.
So my question was, you referring to your Morehouse policy or the state policy? I mean, it's state policy. What policy do you say that they lack of to help you to do your job?
Oh, so great question. I'll take it just from the standpoint for the any epidemic project, but it really could be for some different work that the Institute is doing and the School of Medicine more broadly. It is, to answer your first part of that question, it is from a national level, but it's also thinking about how it can work on a local level. I think that's the priority first. When you think about it from a local level, that means that it's also what is happening from just the standpoint of the different institutions, the organizations, their focus area for providing care or working across the continuum of HIV care. So what I was talking about, the policy piece, this is what we want this to do is to influence what is trained from a curriculum standpoint, for example, right? Like actually making policy for organizations or for them to encourage them to be a part of this training so they can change the models of care from that level, but also the larger, like the policy considerations around what exists at the state level. Georgia, as you know, I think in the recent years has worked on decriminalization of HIV, but this is still a serious issue across several states in the country where there's various policies that are, as I was referring to before, are encouraging stigma. They don't, keep the door open for people to actually report their status because depending on the nature of their having the condition and also whatever the laws might be or the policies that are set into place, they can go to jail for that. So that is, just thinking about in some of these different jurisdictions, how you want to be able to address decriminalization of HIV. That would be a tremendous help, and that would be an asset I would have for those who are assembled here. If that is a consideration, I'm thinking about more like how, from a criminalization standpoint, it may not be necessarily in the statute, but it may be about how like surveillance of information about HIV is being collected. Like data surveillance is also from a policy standpoint what our group has worked on, just from a preliminary standpoint. But I hope that answers your question.
Fundamentally, what we try to do within our efforts is to establish that baseline that policy does not mean just the creation of the laws of the land, but we also want to promote that you can influence and implement policies within your setting where you have influence. So for some, this does mean within the organizational spaces, being able to establish policies around how one is using race as a proxy for their research, clinical research, or if race is being used as a matter of identifying and calculating kidney function scores. We've had projects around that. Also looking at policy in being able to interpret and break down various policies that are set before you. Evan gave excellent examples of just some various criminalization-based policies that are influenced or can be influenced by you all as elected representatives and appointed officials. And so we want to basically take away that thought, that frame of thought of saying that policy equals law, because we do recognize that a lot of the individuals that we engage and interact with are unable within their respective positions to engage in any type of political activity or have some type of direct influence on certain pieces of legislation. So we want them to be able to operate where they are and make determinations, not just being able to create the policies, but be able to influence the policies as well. So going off of research, promoting these data-driven solutions as well, being able to speak with that community voice to share information on what is impacting those right here at the bottom floor so that it can be pushed upstream and a difference is made all around.
So is that what you're asking of elected officials? Because this is the National Hispanic Caucus, the state legislators, and we have our Black Caucus and Native American Caucus. And so I think what the good representative or senator, I can't go that far, is asking is there best practices or policies that work? Because depending on your state, you can do certain things. And like a resident like mine, just getting rid of DEI altogether. We don't know what the unintentional consequences are. So I guess what we're asking for is guidance, and maybe you can all work with our staff in the future, because I know we have another event coming up. But looking at those best practices and what models could work in certain states so we can pass, or, resolution here, we've done some, but pass good policy that's going to help change those infrastructures within our own states.
That's exactly what we're saying, that we'd like to work with you.
We're ready.
And provide the data that you would need in order to step forth in what you're saying is evidence-based.
Yeah.
And it's not just a feeling or a thought, but there's actually data and evidence to carry it forward.
And if I can just offer maybe a closing thought, particularly along the DEI lens, Because I do know that as a diversity inclusion officer, it is at the top of my mind, and I know it's at the top of many of yours as well. Just a few high-level thoughts. One, recognizing that we haven't actually called it DEI as a consistent construct for more than 4 to 5 years. And although the words are important, we can't be so focused on the words side of the work. The work is always work, right? During slavery, it was abolitionist work. Then it was Reconstructionist work, and then it became civil rights work, and it became human rights work. In academia, we called it minority affairs, multicultural affairs. Early 2000s, it was diversity, then diversity and inclusion. It will continue to morph, but the work is always the work.
We understand that work. Many of us have been doing that work since we were teenagers and organizing before we were here. But the issue is there are some states, and that's why we have to look at language and how we do this, because in our particular state, they don't only focus on universities, they focus on public education, and they focus on government entities. And so there are a lot of unintentional consequences on the data we're going to be able to collect. So I think what I'm taking away from here, and this is me just being me, is that there are ways in which we still have to make sure that we're collecting the information so that we can work with our different communities and work within infrastructures that each independent state might have. But this is a great conversation, and hopefully y'all can join us for our reception that we're going to go off to, and continue having this as we move forward, because this is a challenge we're all going to have to face, because the way in which we work with our communities is under attack right now, and it's not just a state level, it's at a national, global level. But thank you again for all the panelists for being here.